Welcome to this e-learning module on the Interim Clinical Guidance for Drug-Resistant TB. This is part 2 and we'll be focusing on the new MDRTB Long Regimen that has just been introduced in October of this year. We are now going to be looking at our long MDRTB regimen, starting off with the one for adults and children over the age of 12 years. This is a regimen specifically for MDRTB that is between 18 and 20 months, and this is new. So up to now we've been using the short regimen and sometimes extending the short regimen, but actually the long MDRTB regimen is a completely different regimen and stands in its own right. The inclusion criteria is based on all of those patients who has got MDR or RRTB and you couldn't give the short regimen. They're probably going to get the long regimen. So this includes patients who's had previous exposure to second-line anti-TB agents for more than a month. And again, it doesn't matter whether they've had MDR in the past and they were cured or whether they were lost to follow-up. From all of those patients, if you've got a confirmed RR MDR-TB, you will start them on this long regimen. Also note that if you now have patients who've got pre-XDR but with injectable resistance, so they are still sensitive to the fluoroquinolones, they can also use this MDR-TB regimen, as well as our MDR-TB patients that has dual mutations, so both CAT-G and an INHA mutation. You may also have patients where you're concerned that they might have some resistance to some of their second-line drugs. So, for example, if the patient has had close contact with another patient with pre-XDR with injectable resistance or with MDR with dual mutation, and maybe you don't have any LPA results on that patient. If you also have patients where you've got confirmed RRTB, MDR-TB, but they're really sick, so they've got complicated, severe extrapulmonary TB, your osteoarticular, your pericardial, not so much your central nervous system, we will have a separate regimen for that. But also if they have extensive lung disease, so severe bilateral cavitation, you'll be using the long regimen, not the short regimen. And again, as mentioned earlier, if you're unsure, should it be long or should it be short, then you're going to be giving them the long regimen. We want to be able to reserve that short regimen for our really, really well patients. And as I've mentioned earlier, you're actually making the decision on the day that you initiate the patient because the regimen is going to look different. We also have exclusion criteria, and that's obviously all our patients who've got fluoroquinolone resistance. So whether it's pre-XDR, fluoroquinolone resistant, or XDR-TB, and where you might be suspecting that the patient might have XDR-TB or pre-XDR fluoroquinolone resistant TB. If you have patients who's got MDR-TB with a HB under 8 and you can't use linezolid, immediately the regimen does get more complicated. You're going to discuss those with the National Clinical Advisory Committee. Now remember earlier we spoke about our group A, B, and C drugs, and the regimen, the long regimen is actually relatively simple because all we're going to do is we're going to give our 5 most important drugs. So remember our 3 group A drugs are levofloxacin, bedaquiline, and linezolid. We're going to add in clofazimine and taurursodiol, and that actually makes up your long regimen. And here it is. So you have a 6 to 8 months intensive phase, and there you can see your 5 important drugs, bedaquiline, linezolid, levofloxacin, your core drugs from group A, and those 2 group B drugs that's added. And you can see that's less drugs than we actually use in the short regimen, but the patient's going to be on it for much longer. And then your 12 months continuation phase becomes really simple because at the end of your 6 or 8 months, you're going to stop your bedaquiline and your linezolid, and you're going to end up simply being on 3 drugs, levoflox, clofazimine, and taurursodiol for a 12-month period. And just note that we're now giving linezolid for a whole 6, potentially even 8 months. And therefore the monitoring of the full blood count and the neutrophil will be an important part of your monitoring of these patients. So let us look at our phases of our long regimen, and actually it's much simpler than with a short regimen. So the intensive phase is 6 to 8 months, but now we're going to be looking at culture conversion rather than smear conversion. And you want your patient by 6 months to be culture negative. If at 6 months the patient is showing a slow clinical response, or maybe there's quite extensive cavitations, quite extensive disease, or maybe there's still culture positive, then you can extend to 8 months of your initiation phase. And your bedaquiline can actually be extended right up to 9 months. Also, if the patient's got extensive disease, late conversion, or when you're not sure about your second line results, or if fluoroquine sensitivity was never confirmed through your DST result. And for all of those, again, you're going to apply through your national committee to check whether it's possible to do so. These patients are also going to be on their continuation phase for a whole 12 months. So at that stage, you can change your levofloxacin to moxifloxacin once the bedaquiline is completed. If you have easy access to moxifloxacin, it's a little bit cheaper than the levoflox. Now, one of the challenges with the long regimen is that you have only 5 drugs, and they're all 5 key drugs. So you might have a scenario where one of the drugs are contraindicated or there may be toxicity. And then the rule of thumb is that you can replace then one of those 5 core drugs with 2 drugs from category C. Do discuss all of these patients with the national committee to check whether those 2 drugs are appropriate. And obviously choose 2 drugs where you're sure there's no possible resistance to those drugs. An example of this would be if you're unable to get linezolid because of an anemia or a low neutrophil count. When we are looking at substitutions and monitoring, just remember when we're giving linezolid, this having to watch the full blood count baseline, 2 weeks, 4 weeks, and then monthly. As we've mentioned, if the patient does develop toxicity on the linezolid, you will have to discontinue and replace with 2 category C drugs. And they also recommend that you do your visual acuity at baseline and monthly on all patients on linezolid because of the risk of optic neuropathy. The other drug that you might run into trouble with is taururzidone. So if there's a history of psychosis or the patient develops active psychosis while on taururzidone, you're obviously going to investigate further, but you may also have to substitute your taururzidone. And again, you have to choose at least 2 category C drugs, as taururzidone is one of your key drugs. Always ask about peripheral neuropathy. That is an issue. Fortunately, we're not using INH in these regimens, so that does reduce the risk somewhat. And there's just an example of some of the group C drugs you can choose from to replace either drugs like linezolid or taururzidone. You have your normal TB drugs, ethambutol, PZA, high-dose INH. You've got your more toxic drugs like amikacin and ethionamide. And you have drugs such as meropenem and delaminid, which are both complicated drugs and not that easy yet to access. We have a similar issue with a long regimen for children than we did for the short regimen, in that we do not have access to bedaquiline. So when we look at this regimen specifically for children, you will again see we are looking at the 3 core drugs. We can't use bedaquiline, so we're going to either use delaminid, which we might not have access to, so pus in the meantime, linezolid and levoflox. We still have those 2 group B drugs as well, but the challenge is that this is more complicated children. Remember, they are sicker, they might have had pre-exposure, and pus is not as powerful drug as bedaquiline. So to try and strengthen the regimen a little bit further, you're adding in either your high-dose INH or your ethionamide, and you will do that according to your mutation patterns. So if you have, for example, INH-A mutation, then you might use your high-dose INH. If you've got a CAT-G mutation, then you may use ethionamide. And in the continuation phase, similarly, you're going to keep those levoflox, clofazimine, taururzidone as your core 3 drugs in that regimen. But because your first 6 months did not quite have the same punch as the adult regimen, if you did use pus, you will actually use pus throughout. So you will use it throughout the whole next 12 months. And again, if your mutations allow, you can add in your high-dose INH or your ethionamide. So just to reiterate a few of the things we've discussed and a couple of new things. If you have a child who is culture negative throughout, is well, relatively well, maybe it was an MDRTB dual mutation, for example, the child's doing very well otherwise, one can decide to give a shorter course, for example, 15 months, depending on if you've got a nice selection of effective drugs in that regimen. And we've already mentioned that you're going to use delaminate as your preferred option, and we're hoping bedaquiline is going to be available in the next year for our under 12-year-olds. Otherwise, when you use PAS, you use it for the full treatment, the full 18 to 20 months. And then, as we've mentioned with INH, we will look at our mutations. So if it's the INHA mutation, you use high-dose INH, CAT-G, you're going to use ETO. But if both mutations are present, you're not going to bother adding in those two drugs. In conclusion, I want to add in a couple of slides on INH monoresistance, which is certainly becoming increasingly common, probably because we are doing LPAs on more patients and are actually picking it up. So in INH monoresistant TB, our regimen basically wants to combine 4 drugs: rifampicin, ethambutol, pyrazinamide, and levofloxacin. And then depending on your INH mutations, you may decide whether you want to add in some high-dose INH or not. Now, to make things much simpler, the easiest thing to do is in practice is just to give Rifafor, which has a bit of INH in there, plus your levofloxacin. And then if the patient has an INHA mutation and you want to add in some extra INH, you can give an additional 300 milligrams of INH to that course. And that makes it a relatively simple regimen to take. With INH monoresistant, we'll follow them up similarly to how we follow up our MDR patients. So although it's only a 6-course, we do AFBs and cultures monthly. Also because there's a risk that some patients that we are thinking is INH monoresistance might actually have some rifampicin resistance that we just haven't picked up. So in summary, of our MDRTB regimens, we now have access to the short regimen for 9 to 11 months with bedaquiline for all our patients instead of the injectable. We're using linezolid for 2 months, no longer have ethionamide, and in our children we'll be using PAS or delaminate instead of the bedaquiline. We also have a long regimen now available for MDR-TB, where we can use our category A and B drugs, those 5 core drugs. And then if patients are fluoroquinolone resistant, we have our long individualized special regimens, or for those patients with TBM. All of those patients will be referred to your centers of excellence for management, and mostly the short and long regimen is what we'll be using at our decentralized sites for patients with RIF-resistant TB and MDR-TB. And remember, we now have to just keep an eye on those full blood counts and neutrophils, do our ECGs, and check our sputum results at every visit. Thank you for your attention. If you do have any questions, do get in touch with your NCAC and feel free to discuss all patients that you are not sure about.